Single-payer healthcare is a system in which a single public or government agency is responsible for financing healthcare costs for all residents, while care itself may be delivered by public and/or private providers. This obviously creates a moral hazard, where individuals may overuse healthcare services or seek unnecessary treatments because they do not bear the direct costs, knowing that someone else, the government, is paying for their care. Moreover, when the costs of my poor lifestyle and health decisions are borne by others, I have less incentive to make healthy choices. If I knew that I would have to pay for my own GLP-1 injections if I got fat, then I would have a greater incentive to maintain a healthy weight. Likewise, if I knew I would have to pay for my own skin cancer treatments, I might take extra steps to protect myself, such as avoiding direct sunlight when the UV index is high and wearing adequate sun protection when I go outside. Examples abound, but you get the point. When I pay the cost of my own health care, I have a greater incentive to make healthy decisions. Moral hazard isn't exclusive to healthcare. For example, in finance, government bailouts for banks that take risky investments and suffer losses encourage further recklessness by shielding them from consequences. Yet this same problem is rarely discussed in healthcare. It's also not as though a single-payer healthcare system could dramatically cut costs without reductions in quality or availability, as the Affordable Care Act already requires insurance companies to spend at least 80% or 85% of premium dollars on medical care. This percentage is known as the medical loss ratio, and data from the Deloitte Center for Health Solutions show that in 2022, it was 87.4%. That same data found only a 2% underwriting margin in 2022. And that year was not an anomaly. The highest underwriting margin from 2012 to 2022 was only 4.2% in 2020. The same data showed that the administrative cost ratios over the same period ranged from a low of 10.5% in 2021 to a high of 12.5% in 2014. Even if single-payer healthcare completely eliminated the administrative costs and underwriting margin, there would still be major changes that, in my opinion, would result in total costs going up, not down. For one, when something is free to the consumer, they will demand more of it. For example, have you ever felt slightly sick and thought, I'll wait a couple of days to see if this passes before scheduling an appointment with my doctor? I know I have. At the time I am writing this, I suspect that my right hip flexor is strained. This negatively affects my life since instead of being able to hit a crossover combo into an up and under layup, I have to settle for a 3-point jump shot. Lame. Most likely this will heal on its own with time, so I ration my limited resources and decide not to visit a doctor or physical therapist. But under universal health care, why wouldn't I try to get a physical therapy appointment? Clearly I, and I suspect many others, prefer to ration our own resources rather than have them confiscated by the government and redistributed according to what the government determines is best for the populace. I much prefer the option to choose between spending on healthcare and on food, housing, entertainment, recreation, and investment. However, under Medicare for All, I wouldn't get to make that choice. There's also the problem of Medicare for All banning private market insurance that covers the same benefits. You may think that if the government covers ACL repairs and other treatments, you would have no need for private alternatives, but that is not the case. Suppose in the future Medicare for All passes and covers ACL surgeries, but the waiting times are unbearable. Without providers being able to accept private insurance or private payments for benefits already covered by Medicare for All, you'll be stuck waiting in line. For some workers, this may mean lost wages that far exceed the actual cost of the surgery itself. For example, suppose the surgery and aftercare cost the provider $30,000, and the patient is willing to pay $50,000 out of his own pocket to skip the line of Medicare for All patients so he can get back to work. Under Medicare for All, this would be illegal unless the provider had opted out completely from accepting Medicare payments. The number of providers who would opt out of Medicare would likely be minimal for a couple of reasons. Number one, it would be hard to compete against a government-financed option that is free at the consumer's point of use. Number two, their customers would have to pay the full cost out of pocket, since private insurance covering the same benefits as Medicare would be illegal. Few people could afford to do this for major health expenses. I also suspect that over time, there would be further restrictions on which providers are allowed to opt out. As wait times increase due to the surge in demand resulting from making healthcare free for consumers, it would be easy for politicians to scapegoat the providers who opted out and further restrict the number of providers eligible to deny Medicare. Especially since the alternative may be admitting that Medicare for All caused the shortage in the first place. The point of prices is to allocate scarce resources to their best use. It makes sense for healthcare providers to prioritize those willing to pay the most, since they are likely to be the people who need treatment most immediately. An NBA player who tears his ACL needs surgery far more than a software engineer who works from home with a stay-at-home wife to take care of him for an extra couple of weeks. However, Medicare for All eliminates the price signal that helps healthcare providers allocate their scarce resources to their best use. Another problem with universal health care is that it reduces the incentive for people to be productive. Allowing direct private payments for health care and private health insurance incentivizes people to produce more, since their dollars can be used to purchase a wider variety of goods and services. A simple way to think about this is that if your resources were limited in what they could be spent on, then you have less of an incentive to produce. If you could only spend your income on tickets to WWE wrestling matches and nothing else, you would likely produce much less than if you could spend your income on food, recreation, entertainment, healthcare, housing, etc. It's also not as if we can simply compare life expectancies across countries to figure out whose healthcare is the best, since that fails to take into account a number of confounding variables such as deaths from car accidents, gang violence, suicides, drug overdoses, and obesity-related health complications. Different countries also measure infant mortality differently. Rather than trying to compare health outcomes across countries with different demographics, environments, and sometimes reporting criteria, it makes more sense to consider whether the basic principles of economics apply to healthcare as they do to other goods and services. Take auto insurance, for example. Single-payer auto insurance would likely result in people driving more recklessly, since they wouldn't have to worry about their premiums going up after a wreck. This, as you may suspect, is another example of a moral hazard. Additionally, with everyone paying the same premium, drivers would be incentivized to purchase vehicles that align with the coverage they are guaranteed. If everyone gets full coverage for free, then people who would have preferred to drive an old clunker with minimal or no coverage for damage to their own vehicle lose out on that opportunity. They may respond to this by purchasing a nicer vehicle since their insurance costs don't change under single payer, but this is a net loss for them, since they would have preferred to drive a clunker with less coverage and spend the money saved somewhere else. In contrast, a free market for auto insurance would allow drivers to choose the option that best fits their needs and preferences. Some drivers may choose limited coverage because their vehicle is old, and any repairs after a wreck would cost more than the vehicle is worth. Some more sentimental drivers may have an unwavering attachment to their vehicle and decide to always purchase maximum coverage, even if it significantly reduces their ability to spend on other aspects of life. Others may have a large amount in savings and purchase less coverage since they can pay for repairs or a new car out of pocket. My point here is not that we should treat people like objects or value them solely for their usefulness as we do with cars. I wholeheartedly reject both those claims. Rather, I am pointing out that individuals are unique, have different preferences, and should be able to weigh the costs and benefits of insurance coverage when deciding which benefits they want to pay for. To the extent any health insurance policy treats people as objects, it seems to be the one-size-fits-all approach of Medicare for All that ignores our differing preferences, situations, relationships, and future expectations. If someone doesn't want to insure against extraordinary, disproportionate care that would cost tens of millions of dollars, they shouldn't be forced to. However, if they want to purchase such coverage, they should be permitted to do so. It is arrogant to assume a third party, the government, will make better choices for individuals than they could for themselves. In short, single-payer healthcare creates a moral hazard, misallocates resources, and disincentivizes production.